Hello, everyone. I have nothing to disclose. Surgical education has gone through a lot of changes over the years. Traditionally, it was mostly based on a trainee's clinical experience, but now programs are moving towards a competency-based training paradigm where there are core competencies that trainees have to achieve. And within this paradigm, one of the more important aspects of it or components of it is assessment in order to first track progress for improvement or feedback, which is called formative assessment, or to make decisions about a trainee's skill level, which is called summative assessment. And not only assessment would work for trainees, but also it could have an impact on practicing surgeons to verify competence and also encourage learning after they finish their residency and fellowship. And there's quite a bit of evidence in the literature to suggest that operative skills do correlate with patient outcomes, with one of those studies by Dr. Berkmeyer, yet we do not have a formal way of assessing trainee or practicing surgeon skill level. And one of the ways in which we could assess skill is using video-based assessments. And maybe some of you have seen this in the SAGES app, but SAGES is prioritizing high-stakes video-based assessment as a part of a master's series in order to verify competence. And in order to use or implement any form of assessment tool, we first have to determine what's out there for us. So the purpose of this review was to first identify assessment tools that have been used to assess laparoscopic benign hiatal surgery, or LBH, and also to evaluate the validity evidence. We included studies till 2017, and we included any study that reported data on assessment tools used in the operating room for any of the LBH procedures. The extracted information included types of tools. So we looked at were the tools global rating scales, where they assess general skills required to perform that task. So a lot of the times they use a Likert scale of 0 to 5, for instance, with anchors at the different points. Or a checklist, which is a dichotomous scale, where the scoring is, yes, they did this, or they did not complete this. An error rating scale is where raters count the number of times a certain error has been made for certain item. We also looked at, were the tools generic to laparoscopy, or were they specific to the LBH procedures? And in terms of the context of the assessment, were they done using video recorded performances, or were they through direct observation? In terms of the validity evidence, in a broader sense, validity refers to, does the tool measure what it intends to measure, and in our case, LBH skills. And we looked at, we evaluated 5 sources of validity. Now, number 1 is content, and that looks like the items of the assessment tool and their ability to measure LBH skills. 2 is response process, which is a source for scoring accuracy. So are the items and their descriptors and the rating scale, is the wording simple and clear, or were there a rating of the, training of the raters and things like that. For internal structure, this is a source for reliability, so consistency of the scores. 4th one is relationship to other variables. This looks at, does my assessment tool score correlates with other measures, either looking at differences between PGY levels or other assessment scores or other known outcomes. And finally, consequences. And this is the intended use of the assessment tool. So if you use it for summative assessment, what happens? What are the consequences of using it for that purpose? In order to summarize the evidence, we use the criteria for rating validity evidence, where each of the 5 sources gets a score from 0 to 3 for a total score of 15. And we labeled a score from 1 to 5 as limited evidence, 6 to 10 moderate, and 11 to 15 strong evidence. So at the end, we screened around 650 titles and abstracts and included 6 studies. Among the 6 studies, we identified 6 assessment tools. 5 were global rating scales, which you can see on the left side, and 1 was a checklist. In terms of the types of assessments, types of items, 2 were generic to laparoscopy, and 4 were specific to LBH. These procedures included nascent fundoplication, hilar myotomy, and preesophageal hernia. And in terms of the setting, the 2 that are highlighted in red were through video-based assessments, and the other 4 were direct observations. In terms of the validity evidence, again, the highlighted ones in red are for video-based assessments. Most of the studies addressed internal structure, where they mostly looked at inter-rater reliability, and the other sources were not investigated too much. For instance, for content, 2 of the 6 studies referenced previous papers for the development process of the tools in the context of clinical assessment, whereas most of the other 4 just reported the items without saying how they came to that conclusion that those items were proper at assessing LBH skills. For response process, only 1 of the 6 items looked at rater training. For relationship to other variables, only 2 tools had evidence for that, mostly being differentiation of the scores between the different PGY levels, and none of the tools had evidence for consequences. And so in summary, we identified 6 assessment tools, and most evidence came from internal structure. And only 1 of those tools had moderate evidence, which was GOES, which is an assessment tool that assesses generic laparoscopic skills. So in conclusion, we found that there is limited evidence for validity of intraoperative assessment tools for laparoscopic benign hiatal surgery, especially in the source of content, among others, and that none of the tools could be used for high-stakes assessment of operative performance, and that future research needs to focus on development of a high-stakes video-based assessment in order to verify competence in LBH. Thank you.